I've been given the task of addressing monoclonal antibodies in multiple myeloma, and there are several targets that monoclonal antibodies have now been developed for, and I'm going to focus primarily on the anti-CD38 monoclonal antibodies, of which right now there are two major ones, Daratumumab and SAR 650-984, sorry. And the second is Elotuzumab, the monoclonal antibody directed against SLAMF7. The key point here is to note that it's a completely different mechanism of action than many of the standard therapies we have now with proteasome inhibitors or IMiDs. And the focus of the talk really is going to be showing how these agents have been able to work on their own, and perhaps more importantly with time, how they're going to work in combination with many of the strategies we already have. I think for the CD38 monoclonal antibodies, it's particularly encouraging that they have had such single agent activity. So there may be some situations where they can remain as a single agent in unique settings. But the combinations that we're seeing most dramatically, initially at least, are with the IMiDs. So both DAR and SAR, as I affectionately call them, have recently been presented with data combining with lenalidomide in the relapse setting. And that was very encouraging. But furthermore, a European group looked at adding an anti-CD38 monoclonal antibody to almost all of the standard upfront regimens that included bortezomib, that included melphalan even, and in all those cases, again, the antibody boosted the effect that one would have seen with those agents alone. We have a precedent here in lymphoma where the monoclonal antibody at the time, Rituximab, and now the others have been added to it, really was added to almost any chemotherapeutic regimen, and there was benefit in the upfront setting, in the relapse setting, even in the very heavily relapsed setting. So that's a similar strategy that we're taking with these monoclonal antibodies now. One of the great benefits of these agents is that they have very little overlapping toxicity, as we would call it, meaning very little toxicity in general, maybe some infusional reactions that we're comfortable managing, but very few overlapping issues with proteasome inhibitors and IMiDs and alkylating agents. So the strategy really is to try combining it with almost every current regimen that we have. Ultimately, as per any agent, it'll have to go through a regulatory pathway and up to a phase 3 trial, and phase 3 trials are soon to come for these agents. But I think it will be not surprising if we find that these agents are really going to be used quite across the board in multiple myeloma. I'd say the take-home message is be on the lookout in the very near future for monoclonal antibodies, especially the CD38 monoclonal antibodies. Our myeloma working group had to each vote on which one group of agents they thought was the most promising for the next 2 years. 80% of us voted for the CD38s. So if the oncologists can remember how Rituximab came and influenced lymphoma, I think it would be a very similar pattern for what we'll see for patients and for therapies in multiple myeloma by adding these CD38s, initially in the relapse setting, but quite likely in the upfront setting before long.